because this is a lot of information late, is that in the margin I put where each objective is. This is not something I will do routinely, but because it was a lot of information and I could not meet with you earlier, I did that. Also, it took me a couple of hours to do it, so it was also to save you some time in getting the information down.
Thank you.
This
You're
is
welcome.
amazing, seriously.
Okay, so we're going to talk, so you haven't had rheumatoid arthritis or SLE either yet. So these diseases are autoimmune diseases. They're very different. They are, RA is one of the most common of the chronic inflammatory arthritis, but it's only about 1% of the population. I think it's highly unlikely, unless you are dealing with a specialty practice, that you would start these medicines. We have very good medicines now, but they are very powerful, and they also have very powerful side effects. So they are best handled by a specialist. Where I think you all will see them, most likely, is in primary care, because that's where I would see them. And what I typically found my role, even though I'm coming from pharmacy, is that adherence was a big thing. So some of it is understanding what the treatment is, how they should be taking it, what are the major side effects, because these drugs carry very big side effects: increase in malignancies, increase in serious infections. I have seen patients die because of those adverse effects, so they are drugs to be very respected. So I think for you all, one of it is having a patient coming in that you know that you're taking care of their primary care needs and they quit medicines. So there are some times where we have remission of drugs for these conditions, but it is rare. So it's knowing where in a process people would be and getting them reconnected. There could be a myriad of reasons why people quit taking medicines. A lot of it is because they get tired of it, or they're worried about, they know the side effects, or they change doctors and there's a lapse in getting a prescription, or they miss an appointment and they won't refill their medicines until they come back, and so the length of time may be too great given the amount that they had. They may switch insurances, then their copay goes through the roof, or they'll come to the beginning of a year and whoever they worked for switched insurances and now they don't cover the drugs that they're on. So there are many, many reasons. So I found a lot of my work with these folks was in case management, trying to get them plugged back in so that we had sustainable treatment. The other is the side effects. So I can see these walking into your emergency room with the problems that the drugs can create, the serious infections. Cancer you may pick up on in a practice, but in an ER it would be liver and renal toxicity are common, and then the infections. And when we're wiping out the immune system, then most of the time you're dealing with very atypical or opportunistic. So you get the otter bugs or the weird bugs. You can get activation of very chronic diseases like Hep B or Hep C or tuberculosis. So you haven't had the hepatitis yet, but you've had tuberculosis. So you know what it means when you activate a latent TB. So you may have a more virulent, or you may have organisms that aren't as responsive to current treatment or usual treatment. So that's the setting I think a lot of you will tend to see these drugs in. And then just intercepting patients' complaints and other more minor adverse effects for them. Not to say you can't, it's just that I think after the end of the hour you'll go, wow, whoa, I don't touch these drugs unless I was part of that practice. The other is making sure they're getting their monitoring. These people have to go for lab and testing very often. So they may have labs in the beginning they may go every 2 to 4 weeks, and then they may go every 3 months. Missing those can put them at great risk. So some of it is, especially if you're in primary care, a lot of what your job is orchestrating care. So making sure and ensuring that they're getting the follow-up that they need. So on the page 3, this is the list of the DMARDs. That's how people refer to them. They're disease-modifying, anti-rheumatic, rheumatism being an old word for arthritis drugs. So a lot of people just refer to them as DMARDs. We will see them again. They're used for a lot of autoimmune diseases. They're used for a lot more diseases that are kind of creeping into the practice. We'll talk about a lot of these again when we get to Crohn's disease and ulcerative colitis. So one of your objectives is to be able to match these to the different categories. So the two big categories are non-biologic and biologic. So the non-biologic are the older medicines. They've been around a long time. They're very effective. They tend to be more non-specific in their effects on the immune system. They tend to affect cascades of reactions instead of a very specific molecular entity. So that's why they're called the non-biologics. They may often be referred to as conventional or traditional DMARDs. Methotrexate, been around for forever. Sulfasalazine as well. Sulfasalazine, we'll see again, it's the mainstay of treatment in ulcerative colitis. Hydroxychloroquine, we've talked about before, and we'll see it in some other diseases. The last 4 tend to be drugs that we term immunosuppressants, even though methotrexate or all of these could be, or also labeled that. So these are very powerful immunosuppressants, and we will use them to, especially in lupus, to induce a remission, and in very severe disease we'll use it to maintain a remission. We also can use these drugs to help decrease the amount of steroid we have to use. So that's that group. The biologic DMARDs are newer. They are more specific. They will specifically go after one part of the inflammatory response. So they may just go after interleukin-6 instead of the whole cascade. So they're specific. They have the more dangerous of the side effects, even though the non-biologics can have that too. We can use the non-biologics in combinations. We don't use the biologics in combination. We'll use one, and then we may use it with a non-biologic DMARD. So you see there's anti-TNF alpha and the non-TNF alpha. Tissue necrosis factor is one of the main cytokines that causes problems in rheumatoid arthritis. It's like the big director. It's the big gun, and the body rolls it out very early. And then it directs all the other processes. So if we can knock it out or decrease its activity, we can have a big impact, especially on more severe rheumatoid arthritis. The other two at the bottom, the Benlysta is primarily just for lupus. We don't use it much. As far as I know, it's not in the recommendations for RA. And then the Janus kinase inhibitor, Xeljanz, is a very targeted therapy. If you watch TV, you will see commercials for these all the time. Xeljanz is all over the place. Lots of commercials about it. Actemra, Orencia, you don't hear Orencia as much. Enbrel, I still see that. You'll see it for, I see these mostly for psoriatic arthritis. The golfer guy, what's his name?
Phil Mickelson.
Thank you. So he talks about these all the time. So that's one place I see them promoting it the most, is in psoriatic arthritis. Okay, questions about those? Be able to match them up, put them in a basket. Okay, let's talk about, let's just do a little bit of pathophysiology. So rheumatoid arthritis is, if you can kind of think about type 1, when we talked about type 1 disease, we talked about people who have a genetic predisposition to getting type 1. Same is with RA. You have to have some type of vulnerability genetically in order to get the disease. In type 1, it was probably played 50% or more of the cause. In this disease, it's about 12 to 15% contributory, but it has to be in place. Then environmental triggers, just like we saw in type 1, also play a role in RA. There are 3 that I found that have been implicated. Smoking is number 1. It's 20 to 40-fold increase in risk for RA. So ways that you can use this. You'll see RA in kids. You can see a juvenile RA, which is very debilitating. Mostly you're going to find these people in their late teens, early 20s is when a lot of them will show up. So one thing I could see as your role is promoting don't smoke around your kids. Don't smoke in the car, don't smoke where they can smell it, because you know about the secondhand smoke and the effects that they can get from that. So smoking is one. Another is the organisms that are involved in periodontal disease. So other organisms that affect mucous membranes seem to also increase the risk. They kind of set off the immune system. The last one is the gut microbiome. So the gut has become an increased focus of a source of disease or contributing to disease. It's a big part of the diabetes literature right now is the things that we eat are so different from the way our genetic makeup evolved or grew or changed over time that because we don't eat more natural foods and we use a lot of preservatives and additives that is changing our gut microbiome and adding to our causing disease. You will hear these things. Just listen to testimonies every once in a while about people who went on a strict vegan diet and how their disease, whatever it was that they were doing, improved. You'll hear these big testimonies. That's probably what this is related to. Because a lot of people can go on it, doesn't really change much of what they're doing at all. They may feel better, but if they don't have any other disease processes that's been aggravating, it may not change that. So those are some of the environmental stimulus that come about. So you have to have both, just like we saw in type 1. It's also like type 1, remember we talked about that immune response took years, like 10 or plus years? So it's the same with RA. Probably RA starts at least 10 years before diagnosis. So when you see it and diagnose it, which is probably another place where you'll end up seeing these folks, is you'll have somebody come in with arthritides, and this will be one of your differential diagnoses. So in these folks, their joints may look normal for a period of time. It may be that they have these micro flares that aren't even clinically people are aware of. And then at some point, something tips the scale and there's a full-blown response by the body. You'll see that the common joints, and this is in your handout, a lot of it's going to be hands. A lot of times what people are going to come to you with are the swollen or tender joints in their hands, fingers, elbows, shoulders, hips, knees, ankles. So a lot can be affected. A lot of it's going to be upper body, certainly can be lower body as well. What happens is you get an inflammatory process set up, and very soon that tissue tends to organize itself, and it will cause angiogenesis. So more blood cell, more arteries and veins will be recruited or formed to supply that area, and it will set up what they call a pannus right here. This is a locally invasive process. It is akin to a locally invasive malignancy. It doesn't reach the grade of malignancy, and it doesn't reach the grade. It doesn't tend to lose its anti-inflammatory responsiveness. And once it sets up, it just is a mighty force in a very small space, and it will destroy the cartilage and it will destroy the bone if nothing stops it. Okay? So it's very aggressive once it kind of takes off, and that's usually when you're going to see it. It's hard. It'll be interesting to watch over your clinical lifetime if they can figure out what the pre-RA is. Like we figured out pre-diabetes. Where can you identify? How can you identify people at risk? and stop the process before it gets to this point. The knowledge of this has really changed the way we treat RA. When I was in your spot, most of the time when we saw RA, it was fairly advanced. People had given them mostly aspirin. We didn't have a lot of these agents. And there wasn't a very aggressive treatment of it. Mostly we focused on lifestyle. How do you cope with the fact that your joints now are destroyed or in the process of being destroyed? Now the movement is to be very aggressive because if you are aggressive, what you want to do is preserve their joints and keep them from becoming disabled. So early, you're going to see as we go through this, we're aggressively going to put them on anti-inflammatories, but we're going to start a biologic right away to stop this, this process from taking over. So you can see here the differences between a normal joint and then a RA joint. And that pannus is that really aggressive, organized tissue that is then destroying the synovium and the bone. So you'll see those when you do your, have you done x-rays yet? Have you done radio? Did they show you RA hands? No?
We got stopped right before.
Somebody else's,
Not x-rays, but they showed us what they
no,
were.
oh, I did, I forgot.
Oh,
So I'll show you in just a minute some of what you'll see on x-ray. But here are your big players, TNF alpha, one of your big ones, interleukin 1 and interleukin 6, I don't see it on here. But these are your big cytokines that are directing this process, and so they are the target of our drugs that we use. So here you see that pannus starting to encroach on the synovium and also on the bone. What you'll also see is a thinning of that synovial joint, and you'll see those erosive edges of the bone in the x-ray. Let me go to that. Okay, so here's normal. You can compare it here. So you've started having a destruction of that joint space. There's a thinning of that cover right here. And then you see erosions, particularly in that one, you've got a lot of erosive properties. So this would be a typical changes related to RA. And then this is, so early on, this may be if it's bothering them enough, this is how they're going to come and present to you. And then these are what we're wanting to avoid. When I was a student, I saw a lot of people like this. So this is what we're trying to stop it right here. Okay. I'm not going to test you over this stuff. You don't see any objectives beside it. I'm just giving you the kind of the background. Questions about that, or any personal experience you've had with it?
My mom has lupus and RA, so her hands.
She has both. Oh
Yeah,
gosh.
her hands look like the second one.
So when was she diagnosed?
In her 40s, and she's 59 now.
Okay, a little bit older.
Well, they knew something was wrong for a long time, but they couldn't figure it out. But she had like a big thing happen, like a big life event, and then like she had a huge flare, and they finally like got the labs to like confirm it. So she had disease activity for a long time, and that's why she kind of got worse before they finally like get it on her.
So how is it? How does it affect her life? What kinds of things does she have to do differently?
She's on so many medications, so funny. But she can't, like her hands sometimes get so bad, like she likes to sew and stuff, and she like, her hands get so bad, sometimes she like can't do like any intricate like details because her hands get so swollen and stiff. And then like, she constantly just gets down, like she can't like do anything. She's got such bad like bone spurs and like all kinds of stuff like in her hips, and like, she has like sit on hot packs all the time, like when she flares up, like she's like down, like she can't do anything for like days.
So she has lots of joint care that she has to do all the time.
She has a lot of joint care that she has to do. She gets a lot of like steroid injections to reduce inflammation. She takes steroids like every day.
Wow.
So,
So sorry. Very difficult.
yeah.
It's All right. Anybody else?
My fiance Zach had it, his hands were, he had it more in the empty joint than that third, the late stage, but his fingers were like totally
Older, the
sideways.
drift, yeah.
Mhm. But he was disabled anyway, so he had all kinds of.
And he is RA, right?
He had it,
He
yeah.
had. And your mother's, for her lupus, did she have a certain organ that was targeted?
I think she has the potential to have lupus nephritis.
Okay.
So, is what they said based on her, the genetic makeup or whatever. But she
Okay.
hasn't gotten to the point to have to do infusions or anything yet, thank goodness, so.
Okay, great. So I asked her that because when you think about rheumatoid arthritis, most of the time people think about just the joints. But in more severe stages of rheumatoid arthritis, they do have whole body effects. So kidneys, lungs, heart are common targets. In lupus, it's all organ involvement. And usually there is a predominant organ. So the kidneys are very, very likely to be affected, or the lungs. Dr. Britton's aunt, great aunt, his aunt, had lupus, and she lived with it for about 50 years. And the doctor, I remember at the end saying, "How did you do so well? How did you live this long?" And she goes, "Because I did exactly what they told me." And she did. She was a Nazi about doing exactly what they did. She lived to 85 with lupus pulmonitis. Okay, so we'll talk about that in just a bit. Anybody else?
My friend has it.
Your what?
My friend has it.
Your friend has it? Young woman?
Yep.
Yeah, that's where I mostly see it, where in young women. Usually we diagnose it, saw a lot in Austin, but mostly women in their 20s is when we would see them come in. And it seems like now I see more milder variants that are also being called lupus that probably wouldn't have been diagnosed in the past. Anything you want to share about your friend in terms of how it may limit or affect her life?
She caught it early. Her dad's a physician. We were training for a half marathon and she just had to quit. She wasn't allowed to finish.
Okay,
So that's about it. It was recent, within a year.
okay. Anyone else? Yes?
It's still hard for me to talk about, but
Okay.
I was diagnosed with subacute cutaneous lupus when I was 13. I had skin symptoms starting at 10, so I'm on Plaquenil every day. I'm in remission most of the time, but fortunately during neuro I had a flare up on my chest, so I actually had to go back to be on Plaquenil recently.
Do you just have discoid?
Being
Holy
monitored,
skin?
adjust the skin as of right now, they monitor me since I've been on Plaquenil for so long, and so they always want to make sure it doesn't progress to anything worse.
Okay. She's very young to have come down with that. She's also telling you about a specific form of lupus. So there is a lupus that just affects the skin. It's called discoid lupus. It's often a side effect of drugs. And that's what I've mostly seen. I haven't seen any other, just primary. And she's told you the drug of choice, which we'll see when we talk about lupus that affects more organs, it's still the drug of choice. So thank you for telling us that. Anybody else? Okay. All right, then let's pick up on the page, top of page 6. So our goal of treatment is remission. So we'll talk about what that means and how you measure it. Or the other term they'll use is low disease activity. So that would be the minimum that we would, or the most we would accept, and our full goal is remission, because that's what will save the joints. And the reason we do that, and we kind of talked about, is prevent the joint damage, preserve function, and improve long-term outcomes. So that's the reason why we're shooting for remission. The non-pharmacologic property, or things that we also try, are there. They're fairly common to all the other diseases we talk about. The only one that we'll probably see as a little bit different is the immunization. So we're going to give them a lot of drugs that are going to suppress their immune system. So one of the things we'll talk about before we start them on a immunosuppressant is we're going to make sure all their vaccinations are up to date. And a lot of those will be adult, oriented towards adults. For pre-treatment evaluations, these are the ones to obtain before starting a DMARD. These are important. I want you to know these. This will be a big emphasis. So one is a CBC, because a lot of these drugs are myelosuppressive, so they will suppress all lines, red blood cells, white blood cells, and platelets. So getting a baseline is important, or picking up problems that need to be addressed prior to the starting of the drug. Serum creatinine, we need to know renal function, because we'll either have to adjust the dose or choose other drugs if they have a renal insufficiency. And it could be that even in a young person, you would see this if they've had disease going on that has not been either treated fully or they've had a lapse in treatment. Liver function tests, a lot of these drugs are very hepatotoxic. They can also be the source of death and liver failure in these folks, so having a baseline and following those will be part of our continuing monitoring. SED rate and CMP, these are going to be our inflammatory markers, C-reactive protein, sorry. So these are the two. There's another one called CPP that we'll also use, but these are the two that you would want baseline, and they'll also be your monitoring that will tell you how well the patient is responding to therapy. Then we're going to screen for Hep B, Hep C, and latent TB, because we can activate all of those if they have them and they haven't been diagnosed or we're unaware, or the patient's unaware of it. The other is we want a baseline eye screening. Kathy has told you about that, so you maybe link that in your brain. Hydroxychloroquine, it's more common with chloroquine, which we're not going to use, but hydroxychloroquine has a retinal toxicity and also a corneal deposits that it produces that can lead to vision loss. So these folks have to have baseline and periodic eye exams while they're on the hydroxychloroquine. So how do we measure disease activity? If you look at the very back of your handout, I have put the disease measuring disease activity instruments on the back of your handout. So page 24, there's the clinical disease activity. That's one. It's a very quick one. So it's giving you the kind of the definitions on the first page. Second page is this one? Maybe I didn't do this one. I put in the rheumatoid arthritis disease activity score. That's the one on 25. The page right after it, page 26, kind of gives you some more information about it. I like this one. It's the more complex. It is a calculator. It is online. You can put it in. This would be one that you would have patients fill out, and then you would have them fill this out each time you see this. This will be one of your ways, your criteria for judging remission. So kind of looking at what is on there, at the very top left-hand corner, you're going to get, that's your marker, inflammatory marker, so a SED rate. The GH is a global assessment. They do one, the patient does one, and the physician does one. And they, on a scale of 0 to 100, they rate how much, what they believe their disease activity to be. 100 being maximal disease activity. So that gets factored in. Then they do a tender and swollen joint count. And so you'll see that they do shoulders, elbows, wrist. For the hand, they do each of the, they do the interphalangeal, the metacarpal, phalangeal, and then the proximal interphalangeal joints. This one includes knee. The other one does not include knee or ankle. It's just all upper extremity. But it's meant to be much quicker than this one. You plug in all this information and it will calculate that DAS 28 score, and it gives you the calculation at the top. Shows you all the variables that it's taking into account. Then at the bottom, it gives you a score, and that score then relates to the disease activity. So remission, low, moderate, or high disease activity. I want you to see this because it's an active part of the monitoring of these folks. It may not be something you do, but it's something you could ask the patient about if you don't have privy to it. There's another one at the back, just gives you there's 3 of these out there, so it just gives you a look at each of the 3. I just chose the one in the middle to give you as an example. Okay, so under D, if you look at what measuring disease activity is, that form has showed us. So we're looking at how many joints are tender, how many joints are swollen, what is your inflammatory markers with your SUD rate or your C-reactive protein. There is then the patient's assessment of their disease activity, and then it would be yours or the provider's disease activity. Our goal is to get to remission in 3 months or less. 6 months at the most, but usually at the 3-month mark, if we haven't got it to remission or low disease activity, then we'll change the drugs. We'll do something different. We may increase the dose, we may add something different. So those really guide when you make a change in drugs. Choice of therapy under E is based on the level of activity, stage of activity. I'm going to show you this in a flow in the next couple of pages. Regulatory restrictions would be like formularies or insurance. Somebody's going to, outside of you, regulate what you can do, say this has to be tried first. Usually it'll be due on mostly to cost. And then the patient preference, because some of these will have different routes of administration, maybe oral, maybe injectable. Usually it's sub-Q, or they'll have to come in and have it done. So those are the things that you would use to choose the drug. Again, treatment decisions, disease activity, disease duration. So we split the disease duration at 6 months. If it's 6 months, it's early, and if it's after that, it's established. Okay? So there's your disease activity, early disease, established disease at the bottom of that page. Poor prognosis. So then they look at the poor prognosis, and it's one of your decision, part of your decision tree. Poor prognosis would be they're functionally limited, so their ability to carry out tasks of daily living would go to joint, probably the amount of joint destruction. Is there extra-articular disease? Do they have heart involvement, lung involvement, kidney involvement? Positive rheumatoid factor, so you can have RA and not have a positive rheumatoid factor. That's usually a better thing. Then there's another set of antibodies, and we refer to those as CPP because the word is very long, or bony erosions. If you look at the next 2 pages, I have drawn out the flow for you. You don't have to know these, but I think it helps in figuring out how people are usually treated. So the first on page 7, it is early disease, and the second page is established disease. So let's kind of walk down through these. I have put down in that blue box at the bottom, did they color it? Yeah, they did. The biologics, or the DMARDs, so you could see those in relation to the flow. So somebody who's had a disease less than 6 months, disease activity, is it low or is it high? So that goes back to that the questionnaire that you used. If it's low disease activity, then the next thing you ask is the prognosis poor or is it not? Okay, and the poor prognosis we just went through. If it's not, then the drug of choice is hydroxychloroquine. That's good because most of the time these are going to be young women. It does not affect pregnancy. You can get pregnant, you can stay on the drug during that. That's not the case for the rest of the DMARDs. Minocycline, I meant to take that out of there. Minocycline does have anti-inflammatory properties and can be used here. It's not very common, but that's why it's there and you don't see it on the list. Another one that might be in there would be sulfasalazine. But let's say their prognosis is poor. This is when then you start going into the non-biologics or the biologics. For low disease activity and poor prognosis, your first go-tos are going to be the non-biologics. Methotrexate is considered the anchor drug in this group. Doesn't mean everybody goes to it first. A lot of folks will. It's very, very effective. And it can be used in combination with leflunomide is usually considered an alternative to methotrexate. We usually don't use them together because they're very hepatotoxic, so you really increase the patient's risk. Or sulfasalazine. Sulfasalazine is usually used in combination with something else. It's rarely in this disease used by itself. Or you could go to a DMARD combination. That combination is going to be a combination of non-biologics. So methotrexate, hydroxychloroquine, sulfasalazine. That's called triple therapy. Or you could do hydroxychloroquine and methotrexate. Okay. So that's the low disease activity. So let's look up the high disease activity. Again, we're dealing with somebody early on. And then we're looking again, do you have factors that would make you think poor prognosis? If it's no, then you're going with the non-biologics again. But you'll see here, instead of going to hydroxychloroquine, they've gone to the higher powered one. So methotrexate more likely would be your drug of choice in this group. If they do have poor prognosis, then they're going to start off with the combination. So usually metformin will be part of that combination. Metformin, hydroxychloroquine, sulfasalazine. Or they could use methotrexate with a biologic. We never do two biologics together, but we can use the non-biologics in combination. Questions about those? Again, it's more to help you get a flow in your mind. Okay, next page, page 8. So here's somebody who has established disease. Let's go down the left-hand side. So disease activity is judged to be low. So you start with a non-biologic DMARD, same as what we did on the other side, except instead of hydroxychloroquine, they're probably going to start with methotrexate. If it's a poor response, then they'll go to a combination. If it's high, if they don't have a poor prognosis, again, as the better off the patient is, the more likely we're going to use those non-biologics, so methotrexate. The more severe the disease, the more aggressive it is, that's when your biologics are going to come more into play. And that's what you see on the other side. You start off with the non-biologics, probably in combination, and then you would head to the biologics if the response is poor. Adding in the anti-TNF alphas or the TNF alphas. Questions about those? Okay. Got it in your mind? Kinda? Makes sense? You know more than you did at 1 o'clock? Yes? Okay. That's our goal. We just measure baby steps. Okay. Page 9. So let's start with mild active disease. So this would be your low disease activity folks. So what does that mean in terms of looking at the patient? Here's your criteria. Less than 5 inflamed joints. Their SED rate, their inflammatory markers are low. Okay. So it makes sense. So this would go along with low disease burden. No evidence of erosion or cartilage damage. Their disease activity on those validated instruments is going to be low. And most of them are not going to have poor prognostic signs. Okay, so this would be the best you could be in terms of starting off. So what do? 2 things we're going to do. So kind of put it this way. First of all is we want to, they're coming to you more likely because they're having pain. So the one thing we want to do is we're going to give them anti-inflammatories because we want to arrest that quickly. And anti-inflammatories act quickly. DMARDs it takes them 4 to 6 months. Okay? So you have to do something, and that something is an anti-inflammatory while the DMARD is getting started. Okay? So we always put them in combination, always. So you have non-steroidals that you can start with, or you have glucocorticoids. Usually the go-to will be non-steroidals, unless you have some type of contraindication. Or you have one joint or very few joints that are bothering the person. Then they may just do intra-articular. then you've gotten away from the burden of the oral steroid or the non-steroidal all the time. Or you could do a combination of, you could do a non-steroidal daily and also just inject those joints. Okay, so that's the combination. Those will not stop disease process. All you're doing is making them comfortable. You're relieving pain. But you will not just stop the march towards destruction of that joint. All the contraindications that we've talked about before, the non-steroidals are still present. Fortunately, most of the time, early on, you'll be dealing with younger patients. But as patients get older, like with Jordan's mom being in her 40s, so then that would have been a different patient presenting instead of a 20-year-old. If you don't have sufficient response to a non-steroidal, you switch them to a corticosteroid. We would try to avoid that if we can, but sometimes the patients, they'll either have ongoing flares or they just won't get significant relief.
Do they smoke?
I started to look that up. I don't know that.
Because
I think you could use a glucocorticoid and steroids on top, or you could do the reverse. You could have them on non-steroidals. I have seen them do this, and then they do microbursts of steroids.
yeah, that's my mom. She's on Celebrex, and then she takes prednisone, PRN,
Okay, yes,
5 to 10 milligrams.
that would be common in someone with advanced disease. Yes, I saw you shaking your head. Did you had Lindsay? Okay, I just saw heads going this way, so I'm like, okay, they know something more than me. Okay, under corticosteroids, talked about Hedgehog. We would never use steroids as monotherapy. We're not going to use the non-steroidals as monotherapy either. But the difference is the steroids are a lot more powerful. So people, in the past, we did use them as monotherapy. We put these folks on steroids and we controlled their symptoms, but we would also give them lots of other problems that went along with steroid use. So what Jordan said brings up a good point, is that you can use, in that first 6 months, when they have flares, you could use a steroid to bring that flare under control as fast as possible and give them relief, but also stop the inflammatory process. So you think about this, I use the word bridge, a bridge from diagnosis to getting the DBARD. Once the DBARD is fully functional or exerting its effect, then you would back off of these. You could put them then on PRN non-steroidal or PRN glucocorticoid. But we would want to get them off the glucocorticoid if at all possible. Questions about that or comments? Okay, so at the very bottom, for DMARD therapy, so if we have low activity, not a poor prognosis, then our preferred is the hydroxychloroquine. Some people will use sulfasalazine, but the traditional go-to is hydroxychloroquine. We talked about female fertility. Again, you're going to use the non-steroidal or the corticosteroid with it until it takes effect. Usually that's about 4 to 6 months. On the next page, if they have greater disease activity, so what would that look like? What are our disease activity markers? Okay, that goes more to, that would be more severe disease. But what are your disease markers? So joints. So what about the joints? Tender, swollen. What do you measure? CRP.
ESR.
And ESR. Okay, so those are the disease markers they're talking about. So if they have greater of that, let's say that doesn't resolve, doesn't come into remission in that 3 month, at that 3 month mark. So what that statement at the top of page 10 is saying, then some people at that point would initiate methotrexate or a DMARD, another one, or a different, yes, another one. They'd add it to the hydroxychloroquine. Okay. So this is the aggressive nature of the treatment. Get the inflammation down quickly, get your DMARD set. You're always monitoring these folks for disease progression, for the amount of flares they're having, response, and side effects. So at the 3-month mark, you're going to start looking at them. Are we making progress? If we are, we keep doing what we're doing until we get to that 6-month mark. If not, do we need to add another drug? At this point, you would add something like methotrexate. In the next section under that blue, initial therapy in patients with low disease activity have poor prognostic signs, methotrexate would be the go-to unless there's a contraindication. Or they could use them in combinations. Again, those combination, most common that's been tested and is fairly well tolerated is the methotrexate, hydroxychloroquine, sulfasalazine. If they could not tolerate methotrexate, then usually the go-to will be that leflunomide or Arava. They're very similar, methotrexate, but because it has some side effects that are fairly intense, they tend to go with the methotrexate first. Okay, under monitoring, frequent, just think in your mind, frequent. So I've got down 4 to 8 weeks, probably every 4 weeks. And then once they're stable, they will move them out. But people would never go more than 3 months without being seen. You're going to reevaluate the disease activity at every visit. People who fail to achieve remission or have very low disease activity at the 3-month, let me read through this. Okay, so I put that in a different place, sorry. So in terms of looking at a failed remission, so you haven't gotten down to that low disease activity or remission on your validated, your inflammatory markers are not coming down. The other thing you would look at is how much steroid are they requiring. If they're requiring a lot more steroid or constant or frequent bursts, then what they're saying in that paragraph is move to a more potent DMARD or a combination or add a biologic. Okay, let's break there. This is a good place to stop.